Thank you, ma'am. Have already given a very nice introduction about the GLP-1 RA receptor agonist. So basically, I'll be talking about a major importance will be given to the flow study, which has been published in July 2024, and following which there have been a lot of upheaval regarding the use of the molecule and recent ADA approval for the use of GLP-1, basically the GLP-1 receptor agonist for diabetic control as well as MASH and many other disease conditions. I have named the talk as like, do we go with the flow actually? So coming to the what, like I said, like the flow study, which was again put forward by one of the famous personalities in the modern era of nephrology, Sir Vlado Perkovich. Everyone should be knowing about him, all the nephrologists, especially nephrologists as well as the cardiologists also, because he's the same person who came up with the CREDENCE trial, and the use of SGLT2 inhibitors has been made very profound since then. So the same person has come up with the new idea of using GLP-1 receptor agonist, Mr. Valdo Perkovich. And the recent flow study has been published in 24 July. So we'll get to the details of the flow study later on. So there's a big connection between the Gila monster and the predator in the Saharan desert and the kidneys actually. So that's where the story has actually started. So we all know that from the Arizona desert, the venom which is seen in the salivary glands of the Gila monster, it has been found that the venom helps actually to reduce the appetite of the humans, and which can be actually used for control of appetite. And as ma'am said, that's from where the first GLP-1 receptor agonist was found actually. And another interesting fact is like that exendin 4 or exenatide has been isolated from Gila monster saliva. And one good thing is like we all know the GLP-1 receptor agonist. GLP-1 actually is the hormone is being cleaved by the DPP-4, and later on, so this one, the one which has been isolated from the Gila monster saliva cannot be cleaved by the DPP-4. So very efficiency is very high for such in this case. So like I said, like the drug made from the saliva of Gila monster lizard is effective in reducing the craving for food, and it was published in April 4th, 2012 in the Journal of Neuroscience. And exendin was produced, and rest all like I said, exenatide was introduced, and it has been FDA approved and used in the treatment of type 2 DM as well as for obesity as well. And we all know why we are talking about all these things: diabetes and diabetes-related kidney disease, which is a major chunk of our CKD disease. We need not mention a lot about that. We all know that. And almost 44 to 50% is diabetic kidney diseases. We already have our superheroes like our RAS inhibitors, SGLT2 inhibitors, and the non-steroidal aminoreceptor antagonists. We all have them, but are they sufficient to, effectively slow down the progression of renal disease, diabetic renal disease? We all know from various studies that we have the RAS blocker studies like RENAL and IDNT. There is a big, as I've shown in the figure, there is a big residual risk left over. Despite the adequate use or of one or two antiproteinuric measures, we still have a huge residual risk left over, which effectively, which eventually causes the progression of the renal disease and worsening of renal function. Patient goes on to dialysis and transplantation and like that. So will this new drug will be able to at least reduce the residual risk left over? Will it be a new superhero for us actually, for the nephrologist actually? So, like I said, whether this treatment will mitigate this risk is still not unknown, but we have very good positive things coming up from the researchers. So what do we know already about this? Like Madam said, like there have been a lot of studies which has been happening in favor of the CV or the glycemic control. Flow study was the first one which has come up for a dedicated nephrology or a dedicated renal aspect study which has come up in terms of GLP-1 RAs. And and again, just going back to the history, there has been a postulate that in 1967 itself that insulin response to oral versus IV glucose, the response of insulin has been very much high for the oral glucose load actually, and so that time itself the investigators have postulated that there must be some gastrointestinal tract or the gut that increases the insulin in response to the meal. Here comes our molecule, which part of our molecule, like incretins. The term has been coined from the intestine secretion and insulin, incretins, and our GLP-1 receptor agonist is a part of the incretins actually. And it has been found that 60% of the insulin that is normally released after meals is due to the incretins actually. So we have two types of incretin hormones, GLP-1 as well as GIP. GLP-1 is like glucagon-like peptide 1 and the GIP glucose-dependent insulinotropic polypeptide, also initially known as gastric inhibitory polypeptide. Both are secreted from the intestine in response to glucose level, which is coming from the ingestion of food. And its action is to increase the release of insulin in response to a meal. So we concentrate more on GLP-1 molecule, which is produced at the ileum as well as the ileum and the colon. It has got a dual action, switch on effect as well as a switch off effect. Switch on effect of the beta cells, which releases the insulin from the beta cells, as well as switch off effect of the alpha cells, which produces the glucagon. It reduces the gastric emptying time, thereby reducing the intake of the food as well as the subsequently reduction of the body weight. And it has got significant beta cell growth effect as well as the prevention of the apoptosis of beta cells. And it acts as the incretins, both the GLP-1 as well as the GIP, both act as a amplifier basically. So when the food signal, when we ingest food, when the glucose load comes, there will be an amplification of the GLP levels, which thereby increases the production of the insulin. Increased insulin secretions will be there, and further on the subsequent actions will happen. So it acts as an amplifier of production of the insulin. And coming to the GLP-1 receptor agonist, the main mechanism of action, like I said, there will be an increase in the production of the GLP-1, and there will be reduction which acts on the beta cell as well as the alpha cells in the pancreas. Increased production of insulin, the glucose will be increased uptake in the peripheral tissues, and there will be lowering of the blood glucose. And there will be a subsequent reduction in the glucagon levels, and thereby reducing the production of hepatic glucose. And this GLP-1, like I mentioned earlier, they are degraded by DPP-4, and which subsequently, excreted from the system. So here, our GLP-1 receptor agonists typically act at this stage where they increases the insulin production and reduces the glucagon production. What are the physiological effects of GLP-1? There is a huge spectrum of action, like ma'am mentioned earlier, which has been trying to be used for many sorts of diseases. In the brain, primarily I said both the alpha cell and the beta cell action on the pancreas, where they reduces the increased production of insulin and reduced production of glucagon. Coming to the kidneys, there are many actions which has been postulated, which has not been completely studied yet. But one thing is definitely there is a increased, there's a natriuresis antioxidative effects, and followed by natriuresis, there'll be reduced, there'll be increased clearance of water, which is a major postulate, major thing which is happening in the kidney. There is also a subsequent postulate that which it helps in afferent. The mechanism of action is via the afferent arteriole. And coming to the brain, it reduces the, it helps in reduce food intake, reduce water intake, and neuroprotection. And like we mentioned in stomach, there will be reduced gastric emptying time and reduced acid secretion. And pancreas, we already mentioned, gut increased growth, reduced motility, and reduced lipoprotein secretion. And liver reduced steatosis. Hence, nowadays the AD has approved in the GLP-1 receptor agonist for the use of MASH. Actually, there will be reduced glucose production. In white adipose tissue, there is increased perfusion, lipolysis, and increased glucose uptake. Skeletal muscle, there is increased perfusion and glucose uptake, and immune system, reduced inflammation. And of course, in the heart and vessels, there is increased glucose utilization, cardiac protection, and increased cardiac output, and increased vasodilation. Now, GLP-1 receptor agonist, it has got both indirect effects as well as direct effects on the nephroprotection. Indirect effect is by reduction of hyperglycemia, and like I mentioned earlier, there will be natriuresis, there will be definite control over the hypertension and obesity, which is an independent factor for progression of worsening of renal function. There will be control in obesity, and there will be definite control over the dyslipidemia part also. And direct effects, like I mentioned, there will be reduced, it has got an antioxidant effect, anti-inflammatory effect, natriuresis, and reducing the glomerular hypertension. Like I mentioned earlier, the proposed mechanisms include anti-albuminuric, anti-inflammatory, anti-atherogenic, and antioxidant effects through protein kinase A signaling, induction of natriuresis, mostly by inhibiting the sodium-hydrogen exchanger, and a reduction in the hyperfiltration. And there is a proposed vasodilatory effect on the afferent arterioles also. So coming to the clinical evidence, like I mentioned earlier, FLOW study is the first study which actually worked on the effect of GLP-1 receptor agonist, mainly semaglutide, on CKD as well CKD patients with type 2 diabetes. Here were there, researchers assessed whether the glucagon-like peptide receptor against like the semaglutide was effective in preventing progression of kidney disease and further CKD also. So FLOW study, which is the evaluate renal function with semaglutide once weekly trial. Here, semaglutide, why was the trial done? Semaglutide has been shown to improve glycemic control, lead to better cardiovascular effects. Its effect on kidney outcomes in patients who also have chronic kidney disease is incompletely understood. How was the trial conducted? Almost 3,533 participants with type 2 diabetes and CKD were randomly assigned to receive weekly subcutaneous semaglutide dosage or placebo. It was a double-blinded study. We'll come to the outcomes, the participants and on later. There was total 3,533 adults. Mean age was 67 years. Men around 70%. And patients included were high-risk CKD patients. And trial design, as I mentioned, it was a double-blinded, randomized, placebo-controlled, and it was conducted throughout the world, like in almost 387 sites in 28 countries. It was started in late 2018 or 2019, and participants were receiving, along with the GLP-1 receptor agonist. They were reserving the standard of care, including the RAS blockade. 1:2 randomization was given to receive either semaglutide or placebo. 8 weeks dose escalation regime was followed, and optimization of glucose lowering, CKD, and CVD standard of care medications were permitted. And it was mainly an event-driven trial, and expected duration was 5 years. So, like mentioned in the chart, there was a screening period for almost 3 weeks, followed by starting with a low dose of 0.2 microgram subcutaneous injection for first 4 weeks, weekly once dosage for first 4 weeks, subsequently escalated to 0.5 milligram till week 8, and subsequently to 1 milligram, and continued. And like I mentioned, it was supposed to be a 5-year trial. It was done in many countries, almost 28 countries, and including India. So the primary outcome was major kidney events, a composite of onset of kidney failure, like initiation of dialysis or transplant or sustained GFR less than 15 ml per minute, sustained 50% or greater reduction in GFR, death from kidney or CV related cause. These were the primary outcomes which are studied. And the secondary outcomes were total eGFR slope, major cardiovascular events, and death from any cause death actually. And associated like albuminuria, GFR, body weight, HbA1c, BP control, limb ischemia rate, all quality of life were also additionally studied. Inclusion criteria, like the major, a male or female, age more than 18 years, diagnosis of type 2 diabetes, and HbA1c cutoff limit of 10 was kept. Renal impaired, defined as either eGFR more than 50 ml per minute, but less than 75 ml per minute, and a urine ACR between 300 to 5000 milligram, or a GFR between 25 to 50, and a urine ACR between 100 and 5 grams was noted. And stable treatment with maximal labeled or tolerated dose of RAS blocking agent was also given to the patient. Exclusion criteria, there are lots of exclusion criteria, but mainly what they have done is the congenital and hereditary kidney diseases or autoimmune kidney diseases were completely excluded. And dialysis patients, be it hemodialysis or peritoneal dialysis, everyone, such patients were also excluded. And another history of patients with a history of malignant neoplasm were also, and transplant patients were also excluded from the study actually. And coming to the baseline characteristics of the patients, age was almost close to 66 to plus or minus 9. So elderly patients were actually considered, and almost all the geographic region was included, and almost the participant rate was almost the same. And glycated HbA1c level was, like I mentioned earlier, it was kept below 10, and average values was around 7.8. And BMI was actually the average BMI was above 30. So basically, the obese patients were considered. And diabetes duration, both more than 15 years and less than 15 years patients were also included in the study. GFR distribution, we can just briefly go through it. Patients having a GFR more than 60 was almost 366 in semaglutide group. Major patients were between more than 30 and between less than 60 kind of group. And albuminuria was also similarly considered. And the albuminuria, almost macroalbuminuria patients had 49%, microalbuminuria 46%, almost similar figures. And CKD stage we already mentioned. And standard of care was given to all the patients, and SGLT2 inhibitors was being used for almost similar number of patients in both groups. AC inhibitors, ARBs, almost similar numbers were actually used in both groups. So almost a very good similarity was there between the both semaglutide as well as the placebo group. And we'll go to the results actually. So coming to the result, the trial was stopped early at a median follow-up of 3.5 years. After an interim analysis showed a very good favorable result for the semaglutide group. basically the primary outcome events was equivalent to 24% lower risk to the semaglutide. And kidney function declined more slowly in the semaglutide group, and adverse events were also very less in the semaglutide group. So with a hazard ratio, major kidney disease events, hazard ratio of 0.76 and the p-value of 0.003. And the major events was very less, 18.7% in the semaglutide group, as well as 23.2% in the placebo group. And even the, we can see the GFR slope also over the period of study, almost 3.5 years. So it's a much better GFR. The GFR decline was very slow, like almost there was a difference of 1.16 ml per minute between the placebo group and the semaglutide group. We'll come to a detailed discussion of the results. So almost 20 patients would need to be treated with semaglutide over a 3-year period to prevent one major kidney disease event. So conclusion, in adults with type 2 diabetes and chronic kidney disease, semaglutide reduced the risk of clinically important outcomes and death from cardiovascular causes. Like there was mentioned earlier, the primary event outcome was 331 in semaglutide group, whereas placebo 410. And coming to the secondary outcomes, like I mentioned earlier, there was a difference of 1.16 ml per minute, 1.16 ml per minute, better GFR slope actually. And here we can actually see an acute decline in the GFR initially when the patient was initiated on the semaglutide. Almost a comparable slope was seen in the placebo group also. But sooner after, from the 12th week onwards, there is a sudden rise in the increase in the GFR, followed by sustained better outcome for the semaglutide group.
Jaiju, sorry for the interference. It is 9:35.
Yeah. Okay, ma'am. Yeah,
I'll to complete it.
Yeah.
Okay.
And the secondary outcomes, there is 18% lower incidence of major CV events in the semaglutide arm, and 29% lower risk of CV death, and 20% lower risk of death from any cause. Other outcomes like urine ACR was reduced by 40% versus 12%, and there was a significant body weight reduction in the semaglutide group. HbA1c as well as systolic BP reduction was also noted, and cystatin C-based eGFR also showed slower fall in the semaglutide group. And subgroup analysis was consistent with a better outcome for the semaglutide group. And coming to the safety outcome, safety adverse events was lesser in the serious adverse events was lesser in the semaglutide group. Only major serious event noted was GI side effects, which we all know, nausea, vomiting, and all those things were very high in the semaglutide. And many patients had discontinued actually because of the GI side effects. So overall, like I discussed, there was a significant better outcome in the semaglutide group. And like I mentioned earlier, obesity is an independent risk factor for CKD, and the control of the obesity weight was also a major effect caused by the GLP-1 receptor agonist, which produced a sustained better effect for the progression of the kidney disease. And coming to the known GLP-1 receptor agonists, semaglutide, dulaglutide, and liraglutide are the major ones which is being studied now. Also the longer-acting exenatide also. Exenatide has been only thing which I want to use is the exenatide has been used advised for use only for patients with GFR more than 45, whereas semaglutide up to 15 we can use. Same with liraglutide also. So coming to the major clinical trials, we have major trials like LEADER trial where liraglutide and semaglutide were the major molecules which has been studied. All have been showing a better effect, and there are many studies which have been ongoing where the bigger studies are ongoing and the results are yet to be published. And like I mentioned earlier, ADA has come up with approval for using GLP-1 receptor agonist for patients with CKD, with proven CKD benefit has been noted. And also it has been advised in use in MASH as well as MASLD cases also. Okay, thank you. Future, see what major things which we have to which are worried about is like are all the molecules, like the mentioned molecules will have a class effect like just like of SGLT2 inhibitors. Is it useful for non-diabetic and non-obese CKD patients? Combination with SGLT2 inhibitors as well as non-steroidal MRAs are still not yet tried. And if combining, how to do it? These are the major questions left in future, and we are all hoping that the new studies will be coming up and will give a positive outlook towards the usage of GLP-1 receptor agonist with in combination with the above molecules. Thank you.